cases that we're optimistically hoping to get through. We have some great fellows that will be presenting our cases for us. We've been fortunate enough to have 3 wonderful fellows this year. We have Daniel Cherian, Zan Nazir, and Greg Callanan. And they're all going to do a rock star job presenting tonight, as they always do in the clinics and also the operating room. For case discussion tonight, we chose a little bit of a different type of topic. So we're specifically focusing on interbody usage in spinal deformity. And I think the true goal and what many of us have nightmares about are these x-rays. And it typically doesn't start with this from the onset, but it's really a cascade of pathology that leads from one surgery to the next, to the next, to the next. And I hope that with some of the cases tonight, we can illustrate some ways in which potentially with interbody devices, we can hope to avoid this cascading effect of ongoing operative interventions. So with that, I'm going to turn it over to Zan to present our first case. And as always, we'll keep a close eye on the chat box for anything that comes up. Zan?
Thanks, everyone, for joining. So this first case is actually it's a 71-year-old male who presented to our office, essentially complaining of low back pain and bilateral lower extremity radiculopathy. Of note, he had a history of a prior lumbar surgery done back in 2020 by an outside surgeon. So his prior surgeries included an L4-5 laminectomy in 2020, an L4-5 fusion, subsequently the year after in 2021, and then L3 to L5 posterior lumbar decompression and fusion. So his main complaints when he came to our office was low back pain, which radiated down to bilateral buttocks. He endorsed numbness, but denied any weakness of the lower extremities. His pain was worse with activity and better at rest. On exam, his prior incision well healed, sensation was intact. However, he did complain of 4 out of 5, or he had 4 out of 5 motor weakness in his right hip flexion and right knee extension. On his radiographs, you can see on the APN lateral, the prior fusion construct from L3 to L5, a prior L3 to L5 laminectomy. And then on the lateral, you can also see significant disc space height loss and retrolisthesis of L2 to L3, of L2 on L3. In terms of his sagittal parameters, you can see a positive sagittal balance and a PI-LL mismatch of around 25 degrees. He came into our office with an MRI. So these are select sagittal and axial T2 weighted MRI cuts, which demonstrate the prior lumbar laminectomy and fusion construct. But obviously there's the L2 to 3 adjacent segment disease causing severe spinal stenosis. On the right image, the right top corner, you can see a right-sided facet cyst, which was causing significant right-sided lateral recess stenosis also. And then if you look at his L5-S1 disc, you can see some early signs of degeneration also with disc bulging. We obtained a CT to look for his fusion, to assess the fusion construct, and you can see vacuum disc phenomenon at L2-3 and also at L5-S1. If you scroll through the axials and the coronals, there was actually a well-appearing fusion mass spanning from L3 to L5. And then also you can see some coronal deformity also at that L5-S1 level. So in summary, essentially this is a 71-year-old male with adjacent segment disease, neurogenic claudication symptoms, lumbar radiculopathy, in the setting of sagittal malalignment at a prior L3 to 5 posterior lumbar decompression. I think important things to consider for this patient in terms of potential etiologies and symptoms of his pain. Firstly, he clearly has adjacent segment degeneration at the level above and to some extent the level below. He also has some sagittal malalignment with positive sagittal balance and a PI-LL mismatch. And then thirdly, his symptoms are likely secondary to neurogenic claudication and his radicular symptom, probably because of that right-sided facet cyst at 2 to 3.
That's great, Dan. Very nice job. Maybe I'll pause to ask Dr. Kalsa. Dr. Kalsa, this is a patient. He's had 3 surgeries in the span of less than 2 years. He's having adjacent segment disease now at 2-3. Obviously this is probably someone that's not satisfied with the surgeries they've had thus far, as it seems to be a revolving door in and out of the operating room. Are you talking to him about potentially taking him up to L2, maybe just decompressing, fusing? In terms of treatment strategies, what are your thought process?
Yeah, Thanks, Dave. Obviously addresses stenosis. That goes without saying. Decompressive laminectomy. Not a great indirect decompression case. I think we'd all agree there. But obviously the underlying generator of adjacent level disease here is PIL mismatch and positive sagittal imbalance. So I think this is a case that you got to restore lordosis, and this is definitely a case that I'd be taking down to the pelvis.
That's great, thanks. Any comments from the faculty or panelists in relation to this?
Yeah, so this is Jens. This is a everyday case. This is a great selection. So for me, one of the things, let's start with the basic caudal segment. At L5S1, how did the foramina look there? And then secondly, it looks like with the previous fusion, I couldn't see the foramina quite well, because that does matter. There are some patients where I think a decompression alone at this adjacent segment actually works just fine. Now he has obviously ugly looking disc disease, and that instinctively leads us towards surgery. But again, I individualize my approach towards the patient. Sadly, in the previous fusion, they did a full laminectomy up to the adjacent segment, which deprives us of the ability, for instance, think about a off-label use of an interspinous spacer like a Coflex. I'd love to punt to my TBI colleagues, maybe Scott Blumenthal, who I think has done that also on occasion. So 5-1 foramina is the first question, and then if the interspinous ligaments are intact, interspinous spacer placement with a decompression of 2-3 might be a consideration. Thanks.
Jens, I think those are excellent points, and I certainly agree with you. You know, the disruption of the interspinous supraspinous ligament at 2-3 is a little problematic, and if you actually look, they decompressed all the way down, including that 5-1 segment. So essentially from, the interspinous of 5-1 all the way up to 2-3.
Then that's basically predilects him towards a thoracolumbar fusion with deformity correction, sadly enough. But this is pointing out that the indiscriminate use of laminectomies sometimes necessitates conversion to a fusion when adjacent segment decompressions alone might work.
Jens, you bring up a real good point. And you see this all the time. If they go up into the next level and take all the ligaments out, then you basically have predestined that patient to have adjacent segment disease. At least if you leave the lamina in, the interspinous ligament, some of the ligamentum flavum, maybe it won't happen so fast. But, and I think that people, at least more modern surgeon, a little more cognizant of that. And I'm not making a comment about the previous surgeon. I'm just saying that most people are pretty aware of leaving some bone intact for the next level.
I just want to ask a question about the indication to include 5-1. Is it because he's had previous posterior decompression, he's just afraid to load that segment? Because his symptoms are 99% coming from 2-3. If his posterior elements were intact, even with a degenerated disc at 5-1, you just save him an awful lot of surgery if you didn't include that in the fusion. So I'm just wondering why you wanted to go take it all the way down to the pelvis.
I think that's a great question, Jack. And this is actually my case.
Okay.
I had big concern, one, about the disruption of the interspinous ligament all the way down to S1. In addition, he is fused a little bit flat, and I worry about his overall global alignment. So it's certainly not something that we take lightly, fusing a patient at the pelvis, but he's also a little bit of a bigger guy. He's a little bit heavier. So a combination of those factors and maybe to a certain degree, a little bit of his dissatisfaction with this continual return to the OR kind of facilitated the decision to take him to the pelvis, but very, very reasonable.
Yeah, this is Mike Jansen. I can't get the video to work. And I agree with all the comments that have been outlined, and thanks for letting me join. But I think, I see this kind of problem like most of us all the time, and L3 to L5 is very flat. And I think if it was only the 5-1 problem, he wouldn't be in your office. He has a very clear-cut anatomical problem at the proximal level. And so in my hands, I would just fix the one level in a 7-1-year-old. He got by for the first 70 plus years at 5-1. It doesn't look horrible to me. There's no pars defect. I wouldn't complicate the surgery. For me, in my hands, I just fix the level above. And I think I can hit a home run to help this patient personally and try to get as much lordosis as possible. I can't quite tell how far out he is, but unfortunately, the 3 to 5 fusion, it didn't really add a lot to help give you much lordosis.
Would you do an ACR at 2-3 then to get as much lordosis you can?
I think that's an option. I mean, sometimes I can't get as much lordosis by trying to put a cage way up front from the back as a T-lift and then try to compress it down. But my goal would clearly be to do whatever I could to fix just the 2-3 level. Yes, you can get a little bit more lordosis if I do an A-lift at 5-1, but I'm just not for sure. And I disagree with Jens that I worry about his foramen and everything at that level. And then when he has such a clear-cut anatomical problem just above this fusion.
Mike, I agree with you. I don't think going up one more level is going to put that much more increased stress at 5-1. And this is a guy that's had one operation from 20, 21, maybe 2 and 21, now in 23. And he's got more time to live for another operation. And I think by doing the long operation, you sort of set him up for the next level.
I think that brings up the question is how many levels of lumbar fusion are you willing to stack on top of a unfused 5-1 segment? And is that a age dependent consideration, different in a 70-year-old versus a 50-year-old? What are folks' thoughts there?
Well, I think, and Mike Jansen, if this was a woman and had some coronal plane deformity too, and clearly osteopenic, that changes everything. But adding one more level to this, first of all, I don't think 2-3 is moving hardly anyway. So you're not adding more levels of fusion because 2-3 is severely degenerative. It's highly stenotic. The facets are huge. It's probably so ankylosed that talking about fusing that level adds stability, maybe a little more correction, a whole lot of decompression, but I just don't think it's going to change much of the mechanics because it's not a very mobile segment to begin with.
Great conversation. Zan, do you mind finishing up just kind of with what we did and then we can move on to the next case?
Yep. So we ended up taking the patient to the OR, stage procedure. The first procedure consists of the L5 S1 A-lift, and then the 2-3 lateral interbody fusion. And then following day, we took the patient back for a posterior percutaneous fixation from L2 to the pelvis. I think you're controlling the screen, Dr. Casper.
Okay. Great. So, I think, posteriorly, it's nice that, we can do this percutaneous. We avoid disrupting the tension band at 2-3. We maintain all that soft tissue envelope that's been disrupted multiple times. Very rapid recovery. This patient left post-op day 2. I think all good points in terms of the fusion segment, whether or not we include going down to the pelvis. For me, I agree, there's not a lot in adding on to 2. I worry about an L2 to 5 fusion with no posterior, intraspinous, supraspinous ligaments in 5-1 and a bigger gentleman, but I think certainly a lot of topic for discussion. All right, Dan, ready to get the ball rolling with our next case?
Yep. All right, so this one's a 29-year-old woman with Ehlers-Danlos, had kyphoscoliosis that was treated by an outside surgeon when she was an adolescent with the T10 to L2 anterior spinal fusion. She's, over the ensuing years, developed some significant pain that didn't respond to non-operative management, presenting with right worse than left, lower extremity radiculopathy, also with low back pain. You've got her AP and lateral radiographs shown. She also presented with some chronic altered sensibility about all of her toes bilaterally. Her situation was complicated by a MVC a couple of years prior to her presenting to us. She had numerous surgeries related to that, with exacerbation of some of her back pain. And then in terms of her exam, the most notable thing was her 4 out of 5 right hip abduction on the right side. And then on flexion and extension radiographs, you can see both. You can see her distal junctional kyphosis and then the instability at that distal level. And then full-length images, again, showing some of the deformity that she has on the coronal plane, and then also the sagittal plane, that distal junctional kyphosis there. And then just going through the MRI quickly here. The main thing here is at the distal level, she's got some central and foraminal stenosis. So our options at this point, given her her weakness, her low back pain, her radiculopathy, potentially removing her old implants, considering some sort of posterior fusion with or without an interbody. What levels would you do, and would you consider biologics?
Great, Dan. Do you mind going back to the scoliosis films?
Yeah, sorry, it's
great. And I'd love to get some of the thoughts of the panelists. Obviously, this is a young woman. She's 29, pretty significantly disabled by this. So, obviously not a great conversation when we're talking about lumbar levels. But any thoughts on what's the appropriate treatment for this?
Dave, before you dive into that, Dr. Chapman has a great commentary in the chat just regarding on folks with these hypermobility disorders and preoperative cervical imaging, flex sex, which we did do here. We actually had an MRI on her as well, just previous, prior to diving into things here. But I'll kick it back to you.
That's a great point, Jens. Rick, any thoughts on a case like this?
I mean, go ahead.
Sorry. If she shows up in my clinic, I'm going to send her to Philadelphia, to UPenn. First thing.
I was going to send it to you, Jens.
She'll make a round trip around the U.S. There'll be a lot of opinions. I mean, this is one of the more frustrating disease entities that we have, because again, it's literally all or nothing. And this is actually one of the rare patients where I'd definitely get a bone scan. I'd get a CT myelogram of a thoracic and lumbar spine. There's obviously rotatory deformity present. And I would also think about a left-right bending film. I rarely get that in adults, but in her, this might matter. Any fusion that we do in a patient with this disorder is highly problematic, as it will propagate to the point of possibly a craniopelvic fusion. And I know of a couple, I've never had to do that, but I've seen a couple of patients with that. So whatever we do is a staging procedure on the way up. And as I see this right now, I really don't see a great option. If you decide to do surgery on this patient, I'd get to know this patient well over a year, maybe two. I would probably think that she'd have to have a coronal deformity reduction. This is actually quite difficult surgery, and probably go upper thoracic spine to pelvis. I mean, I have to say, if I then decide that this patient really can get better with my candidate after my workup, as discussed, I would think about a upper thoracic to pelvis fusion.
And Dr. Chapman, this is a patient of mine, and I'll say, yes, and yes. Did not want to operate on her. Got to know her very well. Kicked the can down the road for probably about 2 or 3 years. If you actually notice on her early X-rays, she had a spinal cord stimulator. The only thing I would agree to do for her was take out her spinal cord stimulator. Reading her the Riot Act, I don't normally do that because I say, hey, this isn't going to help you at all. But she actually, it's a pretty thin female, and the pulse generator was actually irritating her belt line. So that's why I ended up taking it out. But after that, kind of lost a follow-up for a little bit of time, and then she came back, and it still didn't want to do anything for her, quite frankly. But before we kind of dive into how we bit the bullet here, love to hear some other feedback as far as this, controversial case.
Can I make one more comment? So these standing X-rays obviously are very sub-satisfactory. She does have a level shoulder girdle. Can you toggle back again to this? It looked like a supine image. Go back a little more. Yeah, so I don't know whether this is standing film or supine film, but this looks actually way better here. This is one of those patients where when you get supine AP X-rays and they look a lot better. My worry in a patient like this is that this is actually a hypotonic patient, meaning they have a poorly developed extensor musculature and buttock musculature. And these are, again, very problematic cases because they'll fall forward. She also has a forward tilted neck. So again, I want to raise my gravest severe concerns about this patient and what is going on with her. So just want to point out differences of supine positioning, and for instance, a simple recumbent test where the patient lays down flat on the exam table to look for rigidity or flexibility of a curve.
Jens,
Yeah.
you know, you said you would go to the thoracic. How high would you go up? Because it looks like she has a compensatory curve at the cervical thoracic junction. If you straighten her up too much, then her head is going to be tilted over to the left.
Yeah, no, so this is a very good question. So the coronal deformity is brutally difficult to correct, and that basically starts from the pelvis up. So the key thing is from the bottom segment up, going through the concavities and straightening that out. And the thoracic spine, if you look at this, actually straight. So that old lateral fusion was actually pretty straight. And this is, again, why I would want to get left and right bending thumbs in this patient to look at what the thoracic spine does. You're very perceptive in your question. Thank you.
Will anyone utilize Scout CT or MRI coronal kind of prelims or actual coronal cuts here? Also give you some feedback as far as, you know, taking gravity out of the equation, maybe in lieu of bending films?
Absolutely.
Yeah.
Yeah, great point, Amrit. And I think that's something, you know, exactly that we can lean on is that Scout CT is the patient supine, non-weight bearing. Dan, do you mind kind of transitioning into kind of what Dr. Colso was able to do for this patient?
Before you do
Yeah,
that,
so-
can I ask a quick question?
Yeah, go
Jens, Mike Jansen, why would you wait a year or two to get to know this patient? This isn't a chronic back pain patient. This is a patient with a clear-cut deformity and a clear-cut collagen disorder, similar to operating on a Duchenne's kids to some extent. You know the natural history. And if she's really impaired, why do you got to follow them like a chronic pain patient for a year or two to figure out what to do?
So this is a good question. So this is a complex patient, and nothing is easy in these patients. So for instance, one red flag waving into my face is the history of a car crash. And I want to make sure that I understand what the implications there are. And I want to make sure that this patient is going to be compliant with my post-operative regimen. For instance, in a major fusion, I'd have to make sure that she is compliant with pulmonary exercise. I put every patient in my own rehab program, and I want to make sure they're compliant with that to the best possible degree. So I don't see quite the desperation and the urgency to rush in on anything because there's no discernible neurologic deficit. And it is not clear that surgery can really, quote, cure this patient under any circumstances, but open Pandora's box for a legacy of fusions all the way up to the cranium. So that's why I'm very cautious about this.
All right. So our surgical plan was a L23, 3-4 lateral, and then L4-5, 5-1 ALIF. And that was going to be followed up with the T12 to pelvis posterior spinal fusion. And these are our images after our ALIF. And then here's our completed construct.
And this was done percutaneously, Dan?
I believe it was, yes. Amrit, do you recall?
Yeah, this was perk. The mindset there was to just, you know, in a hypermobile patient, minimize the posterior soft tissue disruption, maintain as much musculature as possible. You know, we did navigate these screws just to creep them around that lateral intralateral construct, which is actually very difficult here. And then obviously normally we're not stopping at T12, but obviously with her construct we felt it's a little bit of a soft landing here, stopping midway through her previous fusion. Again, just with her hypermobility in mind, with, you know, to Dr. Chapman's points as far as just minimizing the you know, the domino effect of spine surgery in a patient like this. Obviously this patient is extensively counseled on the repercussions at 30 years old being fused to your pelvis, and you know, was fairly reasonable all things considered, and actually had a fairly decent outcome here.
I mean, quick question, it's Harvey. What diameter rods are they and what type of metal?
5.5 titanium.
All right, thank you.
Yeah.
Harvey, why did you ask that? Would you advocate for larger ones when you do a percutaneous fixation with a deformity correction, or do you think that that's a good idea here?
I mean, with all due respect, Dr. Chapman, I mean, I don't want to be dogmatic. I just asking. I mean, there's lots of ways. This is a very challenging case. Lots of ways to tackle it. I just personally, I've got some gray hair now. I get a little worried about 5.5 titanium with Perk screws. But again, I'm old, so.
It's the top left screw that got me a little concerned exactly where that's going.
Which screw? I'm sorry.
Top left in the construct, I can't quite see. I only see the
T12
head.
screw.
Yeah, I
Yeah.
couldn't tell what level it is. Yeah.
They're like out in screws, honestly.
Okay.
Because she had really atrophic pedicles up there.
Uh-huh.
Yeah, they're in vertebral body, but they're probably starting pretty far out on the TP.
Okay.
Just kind of the best we could get. And I think to the point of rod selection, how many rods, obviously I'm a big proponent of 3-4 rod constructs and kind of lumbopelvic fusions, larger constructs. I think you quote unquote get away with it sometimes when you have anterior interbody support, in addition to kind of minimizing posterior, muscle dissection. And thankfully, this girl's now, I think, at least 2 years out now. No, no pseudo issues, no rod breakages.
And what did you use for your biologic up front?
Just a high quality DBM. Yeah, I don't like BMP in the interbody space if I can avoid it.
Why is that?
I've seen radiculitis issues, particularly with direct laterals.
Mm-hmm.
And what about posteriorly? Same thing.
Posteriorly, just drill out the facet joints and pack something like DBM, as far as I remember.
Somebody in the chat room said, with just using 2 rods with somebody with a connective tissue disorder, should you use more than 2 rods, use like 3 or?
Yeah, I mean, I think once you're using additional rods, you're straying away from the percutaneous construct here. So it's just not technically feasible. I agree. If there's there's no A-lifts and laterals here, it would be it's 100% the right answer to use additional rods. But I do see these constructs succeed with the intercolumn support with a less robust posterior rod construct.
Looks like Dr.
So a
Chapman
comment
has
I would
the
make,
same
I mean,
raise.
with all due respect, should we abandon the concepts of deformity surgery to accommodate Perk screws, or do we abandon the concepts of deformity surgery for MIS with inadequate rods?
Well, I mean, I think if you're getting into like the degenerative conversation and value of Perk screws, I think sometimes an indication for intercolumn support is to be able to utilize Perk screws and reap the benefits of them. Now,
So what are the benefits of Perk screws when the screws aren't in the bone?
Well, I mean, they are in the bone here.
I don't think so.
I agree.
I mean, there's CAT scans to show it.
Dr. Chapman, you have your hand raised. Thoughts?
I wanted to just point out that, for coronal deformities, I think Dr. Maj pointed that out also in the chat room. Most of us would nowadays use a kickstand rod or a supplemental rod on the at least concave side to push that up. So all things considered, I think that the overall alignment as shown here, given this patient's circumstance, is actually very nice. I congratulate the surgeon on this nice doses. But yeah, in terms of ISSG and most of the deformed people that I know here, we would probably advocate for at least a 3rd rod on the concave side to push up the spine, but can't argue with what you have right here, right now.
I think it looks great. Dan, do you mind transitioning to the next case?
I will. Here we go. All right, so this is a 61-year-old woman, prior L2 to 5 laminectomies by an outside surgeon for lumbar claudication. She initially had improvement of her symptoms, but then over the ensuing years had progressive low back pain and then left worse than right lower extremity pain, radiating from her buttocks along the anterior thighs down the leg. She's able to tolerate about a block of walking before needing to rest due to pain. And then she's also had this recent sort of 4 weeks of bladder dysfunction, which was somewhat unclear. And then on exam, her prior incision was well healed. Her sensibility was present to light touch in all of her extremities, but slightly altered. And then also had some 4 out of 5 on the right hip with flexion. Could appreciate her lateral images here. You'd see some instability above and below where her prior laminectomies were done. And then this is not a video, but at the so it's 5, 4, 3 at the 2-3 level, not a lot of stenosis here, but you know there is at least some, and I suspect some of that's going to be, you know, based on her being upright or not upright. And then just quickly go through a CAT scan. You can see some of the adjacent segment disease there.
Did they do a fusion? Looks like there's some fusion at, I can't, you're going
it was just a laminectomy that was done, 2 to 5. Wasn't
like
intentional.
Okay.
So this is a great case. Can you go back to the first image? Eric Olson says the same thing that I'm doing. So go to the second slide. Look at that AP.
Sorry,
so there's an AP, yeah. If you, as I magnify that on my little iPhone, this is a bad right hip with cystic disease. And she has like a 1 millimeter cartilage. She has an old hip dysplasia by the looks of it on both sides. But I would get a hip or pelvis x-ray. I'd examine that hip very carefully. And I'd be darned if this patient does not have hip disease. But if I'd ever consider anything about that spine, that's a red, that I would basically be 100% sure that I've sorted out that hip. But I would put my money, and I'm not a betting man, to be frank, onto hip. There's multiple cysts in both of those hip joints. So for me, that's a hip disease until proven otherwise. And the x-rays on the spine are a accoutrement, but not the main problem.
Yeah, that's a great point. And as you'll see, that was addressed prior to her our intervention.
Great pickup, Jens.
All right, so at this point, open up the panel as far as what your treatment modalities would be.
So I'll also chime in here. There's actually a progression X-ray that I don't think got thrown in here, where there was really a fair amount more segmental kyphosis occurring at that 5, 4, 2, 3 segment. Beyond this, so I was following this patient for some time, and you know, her most recent X-rays prior to signing up for surgery, she was, you know, very, very clearly unstable, that 2-3 segment, even more so than it probably looks here. So to your point, Dan, you know, an MRI is a static study of a potentially dynamic problem. And, you know, there was very clear instability at that 2-3 segment with really progressive kind of segmental kyphosis.
Yeah, thank you.
When you refer to instability of that segment, are you just referring to it's vertically unstable? Because it doesn't look hypermobile to me. It doesn't look like a spondylo. So
Yeah.
what are you referring to?
Yeah, exactly. I mean, it wasn't necessarily translating as much. It was just, a severe post-laminectomy kyphosis problem. I thought we were going to include that X-ray, but
Well, she's rocking pretty much, Mike.
yeah, and I'll tell you, she's doing that like to the extreme. So this was probably an X-ray, probably from 6 to 9 months prior to operative intervention.
Sure. And I think because of that segmental pathology you talked about at 2-3 and 3-4, that's why she's so hyperlordotic, as we all know at 4-5, is trying to compensate for all that, the segmental pathology at 2 to 4.
Yeah. So, my mentality for this patient was obviously correct the kyphosis, stabilize the segment, minimize the extent that we have to kind of stabilize things. We elected to do an ALL resection with a hyperlordotic lateral cage, and then stabilized it. I think we did 2 above, 2 below. Dan, if you want to.
Yeah, sorry, I'm trying to move forward.
If I could, do we have pelvic incidence, lumbar lordosis? Where is the kyphosis exactly?
Sorry, Harvey. The kyphosis is above the laminectomy.
I mean, do we have measurements on it, or like what's the degree of kyphosis? What's the lumbar lordosis? Like, what exactly are we trying to correct here? Like, how much kyphosis? Like, what is the degree of kyphosis? The fundamentals of deformity surgery. Like, what exactly are we trying to correct here?
She was about probably 15, 20 degrees segmentally kyphotic at that one segment.
But do we have the measurement? Let's get the measurements. What's the pelvic incidence, lumbar lordosis, pelvic tilt, sacral slope? Do we have those measured out?
I don't have them here on the slide.
That's very unfortunate.
You normally get a full scoli on all those patients, but you leave just 1 and 2 level fusion.
I think it's always prudent. Obviously look at the bigger picture. In this case here, you can also see that we had her get, after the first time I met her, we had her get hip replacements prior to going down the road of her low back conditions. That was a great pickup by Dr. Chapman. But the problem here, this is a post-laminectomy kyphosis case, basically. And so,
but where is the kyphosis?
It was at the 2-3 segment.
And what's the measurement? And what is the lumbar lordosis, pelvic incidence, sacral slope, and pelvic tilt?
Got it. Well,
I mean, you have it measured out, right? Pre-op films, and so we can measure the pre-op versus post-op correction, right?
we do. We don't need to.
So what are they?
Nail the fellow to the cross here, man.
No, not at all. Just for educational purposes, we had a pre-op plan, post-op plan. Like, what are the measurements? What's the kyphosis? What's the overall alignment? Come on, guys.
That's fair. So, in my mind here with a intercolumn resection, I think it's a fairly destabilizing procedure when you intentionally resect the ALL. So not a time that I will just do a, 1-level fusion to back it up, particularly in light of this lady had a pretty wide laminectomy extending above and below that segment.
So did we fuse this patient without measuring any of these angles? Like, nobody knows the overall sagittal alignment, coronal alignment, pelvic incidence, lumbar lordosis, sacral. Like, these are fundamental concepts of deformity. Surely we.
Yes, Harvey, they're there, but we don't need to be.
So what are they? What are they?
I mean, I'm going to have to bring up my office note if you want me to.
That's okay. It's unfortunate it wasn't prepared before the presentation.
Yeah, I think, Amrit, all good points in relation to kind of the ACR and how we reconstruct for that issue. Greg, let's get into our fourth case. We have 2 left. I think the next 2 will really highlight some of the things that we can hopefully correct with interbody devices.
Sounds good. So case number 4. So this is a 63-year-old female with complaints of axial low back pain and bilateral lower extremity radiculopathy. Next slide. Current pain is localized to the low back with radiation down the posterior aspect of her bilateral lower extremities. The pain is worse with activity and is improved with rest and lying supine. On physical examination, patient's prior lumbar laminectomy incision was well healed. Sensation was intact to light touch, and patient had 5 out of 5 strength bilaterally, with the exception of 4 out of 5 knee extension as well as ankle plantar flexion. So here we have a AP and lateral radiograph of the lumbar spine demonstrating multi-level degenerative changes. You can see a grade 1 anterior listhesis of L3 on L4, as well as L5 on S1. And we can see that there's a slightly more impressive anterior listhesis of L4 on L5. So our standing dynamic images, flexion and sensor radiographs of the lumbar spine demonstrate mobile spondylolisthesis at L3-4, L4-5, as well as L5-S1. So we have now select sagittal and coronal lumbar CT cuts demonstrating no evidence of autofusion. You can see the aforementioned spondylolisthesis multi-level. You can also see vacuum disc phenomenon at L4-5 as well as L5-S1 with advanced disc space collapse at L3-4 noted. And here we have select sagittal and axial T2-weighted MRI lumbar spine cuts demonstrating multi-level central and lateral recess stenosis at L3-4, L4-5, and L5-S1 respectively. And we can also see that there's evidence of the prior L3-4 and L4-5 posterior decompression noted. So some surgical options. The conversation essentially revolves around the idea of either revision decompression in isolation or decompression with fusion. With respect to decompression with fusion, we have the options of going posteriorly, an anterior-based procedure, or a combined 360 fusion, trying to be able to take us back to the images from my computer. Yeah, great, thank you.
That's great. Maybe we'll pause. Jens, here we have, a patient that underwent open laminectomy, L3-5. Originally had a little bit of anterior listhesis with a 2-level degenerative spondylolisthesis. And unfortunately, over about a 1.5 years, developed this kind of progressive deformity.
I think these are all great cases. Now, just comment that, sometimes people come along a little bit critically, but these are great cases. And I think we can all agree that we have certain principles, but we don't want to be too harsh with one another here. My main worry is, aside from the stepladder spondylolisthesis phenomenon, this is usually seen in connective tissue disorders, so rheumatoids, steroid users, etc. So my first question is are there any inflammatory disease stigmata, specifically RA, or is this a steroid-taking patient? Do you have any information on that?
Per the office documentation, there wasn't anything noted significant in the patient's prior medical history with respect to an autoimmune condition, rheumatologic condition that I noted.
Sure. One more question. This is Mike Jansen. Before you go through the options, can you first outline in your mind what is the goal of doing anything to the patient rather than we talk about options? Because I think some of those options are irrelevant if you really tell me what your goal is about helping this patient.
Yeah, that's a great question, Mike. Greg, what's your goal if this lady walks into your office, in five quick months, around the corner, she comes in, she's pretty miserable. What's your conversation look like?
Yeah, so I think the patient's main complaints are the radicular/neurogenic claudication symptoms she's having from likely this dynamic instability picture causing compression. So in my mind, the 2 goals that we need to accomplish would be decompression of the neural elements, and the second goal would be stabilization of these dynamic instabilities at 5-1, 4-5, and 3-4. I think if she had a single level, didn't move much on flexion extension, we could discuss more about doing an isolated decompression and kind of save her the fusion. But I don't know if in this patient, that would be the first option I would be thinking of.
So do you think if your goal is to just realign the spine, that takes care of most of the time the decompression that she needs, because it's a deformity associated with her previous surgeries. So my goal would be to realign the spine, and that would probably solve most of this problem. Now we can talk about the options to accomplish that.
Correct. Correct.
I think that's spot on. Yeah, exactly. When we see these mobile issues, oftentimes when patients lay flat on the MRI scanner, we underappreciate their degree of stenosis, and then they weight bear, and all of a sudden that, small grade 1 spondylolisthesis turns into a grade 2, and it really demonstrates the degree to which they're having that lateral recess stenosis. So that's spot on, and I think a great point.
How large is this patient? She looks pretty big. And did you do bone density or anything before?
It's a great question. I'm a big proponent of measuring the Hounsfield units at the levels that I plan on instrumenting if I'm going in an instrumenting direction. She is a bit larger. Our cutoff for BMI is typically 35. On occasion we do bend that. But DEXA scans can sometimes be a routine portion of my practice if for some reason the CT looks questionable.
And David, what do you use as your normal cutoff for the Hounsfield units? Do you use 190 plus or minus what?
I actually use 120, but I think there are factors that really do play into that. Again, exactly as you said, maybe degree of correction, body habitus, overall health of the patient, other medical comorbidities. But I think certainly some wiggle room within that, but that's typically what I go by.
Thanks.
I was going to comment also on if you go back to the MRI axials, her very arthritic facets are very sagittally oriented. So I wonder, how much of this could be just iatrogenic from midline decompression, and that's why you're seeing the stepwise rheumatoid-like instability. But whenever you're going to do a decompression on somebody with a slip or potential slip, I think the orientation of facets is important to look at when you're making a decision as to whether you're going to fuse it or not.
100% agree. There's a great systematic review on some of the factors, and one of those truly, Jack, being the orientation of the facets. If you see those really sagittally oriented facets, that should certainly raise a little bit more suspicion than those coronally oriented ones. Just in the interest of time, we have one more case to get through. Greg, do you mind just going on to show what we did?
Yeah, absolutely. I would love to. The computer's fighting me. Okay, great. We can see here that what we did was we performed. I'm not even clicking this anymore. Sorry about that, guys. So what we chose to do was we did a 3-level A-lift, and then we backed that up with posterior percutaneous fixation in the back. The A-lift cage was utilized in order to both realign the spine as well as performed indirect decompression. And then the posterior fixation was added in order to increase the robustness of the construct.
Do you have a full-length film post-op, or?
I do not know.
It's a great question, Rick. We do, unfortunately we can't get those in the hospital, but we do post-op. This is a recent case. I would make the argument that, I probably undercorrected her a bit. And then the other argument is whether or not I should have gone to the pelvis with her, kind of based on a few things. I think in relation to, her overall alignment in comparison to her pre-op imaging, I hope we got her a good bit better, and, she's overall happy. But I agree, maybe a bit undercorrected.
What biologic do you use on the A-lift cages? Do you use BMP for this, or still DBM?
I actually use an I factor for most of my interbody work now.
David, are you happy with me? A lot of people say it's equivalent to BMP.
Yeah, I think it's hard to make that argument. I think part of it is these new cages are so robust. I think there's probably a component of the cages themselves, and then also the biologic. I haven't had, I don't have a huge cohort of these, but I haven't had any issues with pseudoarthrosis yet. It just, for me, to be honest, is a little bit of a cost savings in relation to the implant with the BMP for our hospital system.
Just a quick comment, Dr. Casper, is the use of I-factor in interbody cages FDA approved just for the trainees? And if not, how did you counsel the patient regarding the use of non-FDA approved biologics?
Yeah, it's a great question, and it's only approved for FDA approved for 2-level cervical, 1 and 2-level cervical with allograft, and we certainly go through that with all of our patients, whether it's BMP and we're using it, posteriorly, posterior laterally for those kind of indications. We have a space on our consent and actually do a separate consent for non-FDA approved devices. But very, very good question.
Dave, are you doing any posterior reduction maneuvers here? Either like the order that you place your rod down, or any compression, or what's kind of your thought process here coming posteriorly?
Yeah, I think, very reasonable. Sometimes for more mobile, if I have a very out of whack isthmic spondy, I will put in just isolated screws in one vertebral body, typically the cephalad one. And then typically what I try and do is when I go posteriorly, I'll final tighten, say the S1 screws, and then try and pull back those L5 screws percutaneously. Usually when I get into more of these multi-level constructs, it's a little bit more of a challenge to do so. So oftentimes I really try and get as much of a correction as I can up front.
Case. Great case.
Okay.
And I echo the cost savings of the I-factor, because I was the lead investigator for the cervical, is substantial compared to using BMP in these cages. So we kind of did the same thing a couple of years ago.
Okay. I'll move on to the last case here quickly. So this is a 49-year-old woman, adolescent idiopathic scoliosis that was untreated. She presented to us with low back pain, left worse than right, lower extremity pain radiating from her buttocks. She also presented with a left foot drop, had some activity intolerance up to about a block. You can see her AP lateral images. She's got a PI-LL mismatch of about 50 degrees. And then she's got a 55-degree lumbar curve, and then about a 30-degree compensatory thoracic curve.
Question before you get rid of that x-ray, this patient has a substantial pelvic obliquity, and it looks like there's a substantial difference between her hips. And does she have a leg length inequality associated with this that then superimposed on a lumbar idiopathic curve? Or do you have any idea what was going on previously?
That wasn't documented, but that's a good pickup. Harvey, do you recall?
My recollection, I don't think it was the hips. Again, it was a couple of years ago we did this case, 2 years ago, but I don't believe that the leg lengths or the hips were an issue.
Okay. Do I still have control? Yeah. So I've got looks like just a single slice here of her MRI. She does have some lateral recess stenosis, and at that looks like 4.5 and 5.1 level on that affected side. So same sort of questions to the panel. Short on time, but I could skip ahead.
Why don't you just go back to the AP and lateral x-ray there, Dan?
Yeah.
Jens, any thought on levels or potential usage of interbodies with this when you're thinking about a bigger deformity and fusion?
Yeah, of course, that would be the mainstay, and correcting in coronal deformity. Mike's point is so critical, understanding the coronal deformities as we approach this, and obviously multi-level interbody fusion would be nice, starting from the pelvis up. This is again a patient where bone density is critical, and understanding the dynamics of her spine, whether we go to the upper or lower thoracic spine. And offhand, I can't make a judgment call on that, but if in doubt, probably upper thoracic spine. But this might be possible to stop at around T8 or 9 here. I'm worried about her bone density also, just looking at the X-rays. And again, I would build her up from the left side. I do these all posteriorly now with eccentric cages with IDOs, and the lateral stabilization of 3-4. We have a special new reduction tool to kind of seat that on top. But yeah, it's hard for me to decide where I would stop rostally. But this, if I optimize this patient adequately, I would do a multi-level posterior and a body fusion, probably 3 or 4 levels or 5.
Jens, are you still pushing Forteo on your patients preoperatively, or are you seeing some of the endocrinologists using some of these newer anabolic agents? And how do you feel about that?
I feel strongly about it. And again, even 3 months for an anabolic agent are a huge thing. And we're very lucky that we have a mineral metabolism specialist. And sadly, they're so overworked, I have to call him personally every single time for one of those patients. But we usually get them on 3 months of teriparatide and stick with that.
Dan, do you mind showing the initial X-rays and then kind of what happened above the interbodies?
Yeah, sure. So we did a 4.551 ALIF. We did Pontes at the affected levels. And these are her initial radiographs post-operatively. I stitched these together, so I apologize if they're not totally aligned. But she did well initially after this construct for about a year. And then in follow-up, we noted that her rod had broke. She started to develop some pain as well, and kind of at the low back, but no radiating leg pain. She, from our stance, she appeared to be well decompressed. It was just kind of pain related to the or the pseudoarthrosis at that level.
So I think a great case, it highlights we're using 2 interbody devices here at 4.5 and 5.1, and still the concern of pseudoarthrosis and breakage on these big constructs. So it lends itself to Dr. Chapman's point of that kickstand rod or multiple rod constructs. Harvey, what are you, for these bigger corrections now, are you routinely using 3 to 4 rods right off the bat, or what are your thoughts?
I wouldn't say routinely. Actually, the reason I wanted to present this case was I have backed away from routinely doing S2AI and violating the SI joint. So this was a patient that failed. That's why I want to present it. I did traditional iliac bolts. I did an osteotomy and the PSIS to recess the bolts. And then she's a nurse, went back to work, but then she decided to start working out on a rowing machine. And again, it may not have anything to do with it. It could have just been a non-union, but she presented with a broken rod, and we'll show the revision films. The reason I thought this case was good for discussion was maybe I should have done 4 rods in the first place. That's what we did when we revised her. But initially I used, 1/4-inch rods. We had a good correction. The rods broke, and then I had to revise her to 4 rods. And with the 4 rods, then I did S2AI screws. So I thought, in the interest of time, this would be a good discussion for pelvic fixation, S2AI versus iliac bolts. And I'll let Dan present the rest of the case.
Quick question: did you see any osteolysis or anything around that interbody cage to make sure that this is itself a pseudo, or did you guys bend the rod a lot and maybe it just fatigued right there before it went on? I think it's pretty unusual to have a pseudo with that big of a cage in, unless you truly have osteolysis or something.
No, agreed. I mean, again, I'm biased because I'm the surgeon for this case. I did not believe we had a pseudo at the interbodies. The rods broke, so with respect to if the rods break, that may have been a pseudoarthrosis. Whether her activities with the rowing machine contribute to or not, I don't know. But this was a case where, in retrospect, I maybe should have done 3 or 4 rods across the junction, and I didn't, which is why I thought it was important to present. But it was someone who initially, I thought it was a good correction. She did very well, went back to work full time. And then with her activities, whether it was coincidental or not, the rods broke, and then we had to revise it. But I do believe that at the interbody levels, it was a solid fusion.
And then, Mike, we do have
not
CT
even a reviser. I may have just sat on it and watched it just because you have one rod broke, unless you can show me where it was a pseudo. I mean, I don't know. I think you did a great
apologize.
job.
The presentation may be incomplete. Initially, she presented a clinic with one rod broken, and I did wait on it. And then she came back within 2 or 3 months with the contralateral rod broken. And so initially it was one side broken,
okay.
and I said,
No,
okay, let's wait on it. And then she came back again with acute onset of pain, and the contralateral rod was broken. And I apologize that the films don't show it, but at that point we had rods broken on both sides, and that's when I decided, when I felt we needed to revise it.
And Harvey,
Yeah,
what was
Jens,
I would
any
concur.
closing
Great
comments?
case.
Harvey, where was it broken on the left side at the same level?
And again, no, the rods were broken. Again, I apologize, the slides aren't complete. The rods were broken on different levels. And that was when we took her back to revise her. Initially with the unilateral rod fracture, I said, let's wait on it. And then she came back within 3 months with the contralateral rod broken, a little bit different level. I apologize, I don't recollect exactly which one, but then I said, okay, we have to revise this. And that's when I did the 4 rods, S2AI screws to run up the secondary rods.
Thanks.
Very good.
Great correction. As always, thank you to SSF for allowing us to present tonight. We wanted to go with a little bit more of some controversial cases, maybe pushing the envelope in regards to some of these interbody devices. Hopefully, in the future, preserving some of these posterior soft tissues and envelopes to maybe avoid, pushing back this natural history of adjacent segment disease. But thank you, everyone, and we always really appreciate the opportunity to get to show some of our work.
Thank you.
Yeah, we had some great discussions around these cases, Dave. So thank you to you and your crew.
You, Ben, you did great.
everybody.
Thank you for the great cases. We appreciate it. Take care.
Thank you, Ben.
So long, guys.
Have a great evening.